I'm Dr. Alicia Cummings, and in this video, we're going to talk about the different types of errors children often make with the sound and some possible explanations for these errors. So there are two types of errors children commonly make when attempting to produce the When the is in prevocalic position, often at the beginning of words, they will produce a glide sound such as a w or a y instead of the So they'll say wake instead of rake or yest instead of rest, though the w, the w, is the more common substitution. When the is in postvocalic position after a vowel, often at the end of a word or in the middle of a word, they will distort that and turn it into an extended vowel-like sound, which is referred to as vocalization or vowelization. So they'll say cow for car or fama for farmer. So there's that distortion of that R or the type of sound. And people mistakenly think that these vocalization errors are just a deletion of a final consonant. But when you look at the acoustic traces of children's productions of these vocalizations, they almost always are attempting to produce that but they're just unable to accurately achieve the constriction necessary for an accurate sound. And so instead it comes out as this distorted vowel-like production. So speech sound disorders are usually referred to as being functional or idiopathic in etiology. This means that the cause of the disorder is unknown. So children who have a diagnosis of speech sound disorders present with normal hearing, normal intelligence, normal social, emotional, and behavioral skills. This means they have no other concomitant disorders. They don't have language impairment. They don't have autism. They just can't say their sounds correctly for one reason or another. But that being said, there can be some structural variations which can impede a child's ability to produce that correctly. So ankyloglossia or tongue tie refers to when the child has a restricted tongue movement due to this connection here underneath your tongue is called the lingual frenum or the frenulum, and it doesn't allow for full range of tongue movement. So there are anterior tongue ties such as this at the front of the tongue. There are also posterior ties which restrict the tongue body movement at the back. And both of those can impact how a child produces their correctly. There is mixed evidence about whether or not this tongue tie should be released, usually these days with a laser. But if a child is inaccurate or unable to lift that tongue tip up to the top of the mouth at the front or lift the back of the tongue up to achieve a k or g or sound, that might be a reason to pursue an evaluation of that tongue tie by a qualified otolaryngologist. It's something to consider. We can attempt to do speech treatment without a tongue tie release, but sometimes that release can make children's speech production improve a bit faster, or it may not make any difference at all. So it's just something to consider on a case-by-case basis. Another tongue-related disorder is a class of oral myofunctional disorders, which include phenomena such as tongue thrusting, unusual oral movements, finger sucking, lip insufficiencies, and dental and oral structure deficiencies. So there's a variety of definitions of what oral facial myology is. I can't even say it. But one definition is that it's the study and treatment of the oral and facial muscles as they relate to speech, dentition, chewing, swallowing, and overall mental and physical health. And so the vast majority of oral myofunctional disorders are related to the tongue resting posture in the mouth, and specifically its abnormal resting posture, which then affects dentition, your teeth, as well as hard palate formation and shape. So tongue thrust is one issue that is commonly addressed, but keep in mind, tongue thrust is actually an outdated term, as there are people who actually have a tongue thrust and do not actually use more force against their teeth than those who are non-thrusters. Instead, we need to think about this as an oral muscle pattern disorder. So to explain, at birth, all infants are tongue thrusters because the tongue fills their entire oral cavity, and that makes tongue thrust obligatory. So that is, in order to swallow, as they're nursing, children place their anterior tongue against their front gums and teeth to make a seal so that the food and drink does not escape their mouth. However, later children switch from this anterior tongue position to a more advanced superior tongue palate seal, where the blade in the medial part of your tongue, the middle part of your tongue, is pressed against a hard palate during swallowing. And this is also where your tongue should be at rest. It should be pressed slightly against the hard palate, well behind the front teeth. And this resting placement, if it's too far forward, can be negatively affected by open mouth breathing, thumb sucking, pacifier or sippy cup use, etc. And so, as we can see here from this picture, it's a fairly severe case. Tongue thrust frequently also occurs with malocclusion, meaning misalignment of your teeth, and it can just impair and impede normal teeth eruption, so how the teeth are aligned in your mouth. And so this, when we have an oral myofunctional disorder, it's often also associated with a frontal lisp, such as when kids say, they'll say thun for sun and zip for zip, where their tongue is between their teeth, maybe even sticking out between their teeth. So in general, these distortions of S and Z are commonly associated with children who have an oral myofunctional disorder as compared to those who don't. Oral myofunctional therapy is typically provided by an SLP who has gone through extensive training and has a very good understanding of all the oral and facial muscles. But research is a bit mixed in terms of whether oral myofunctional treatment can actually improve speech sound disorder errors. That being said, if children have both an abnormal resting position of their tongue as well as a speech disorder, it might be beneficial to consider addressing that tongue placement as well as pursuing speech treatment proper. And we think there might be a subgroup of children whose speech disorders are directly related to that tongue placement. Specifically, if your child only has a lisp like, that really might be related to that tongue placement. If we can fix the tongue placement, then that lisp might go away and their speech disorder might be resolved.